Hello, everyone. Welcome back to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I am with my co-host, Dr. Johanna Richey. Hi, Joe.
Hey, Jeff. How you doing?
I'm doing wonderful. Before we got started, we had quite a football conversation, and our guest today is wearing his Philadelphia Eagles pullover. Dr. Allan Jacobs, welcome back to Dean's Chat.
Well, thanks for the invitation. I appreciate it.
No, it's great to have you. Just so our viewers and our listeners know, we already did a Dean's Chat with Dr. Jacobs. It was episode 104, and it became evident with all your insightful observations about our profession that there was no way we were going to do justice to your career in 45 minutes. So we scheduled episode number 2 with Dr. Jacobs. And again, we'll go with first names. Is that okay? Joe, Allan,
Sure.
and Jeff? Okay. And so we appreciate you jumping back on. I have a whole list of questions, and we're going to actually do something new for Dean's Chat. I'm going to do an unplugged version of questions for you, the second half. So the first place I wanted to start, Allan, we talked about your residency training. We're going to go on, discuss that a little bit more. But you were the scientific chair at the American Podiatric Medical Association at a time when there wasn't a lot of evidence-based medicine. And I know you've been a proponent of evidence-based medicine. What was it like to be a scientific chair, when you were with APMA?
I chaired the national meeting for 3 years. The meetings one was at Disney in California, one was in Vegas, and the last one I did was combined with, I believe, was Region 1 in Boston. And back then, I had met with the powers because I've never been a political type person. I've never had the ability to sit in a room if I think someone is not telling me the truth and be nice to them. I think it's one thing to disagree. It's another thing when someone's willfully manipulating and lying to you. And I just have never had that ability to sit there and negotiate with people once I know that I'm being gaslighted, as they say these days. In any event, back then, the meeting was combined with the House of Delegates. And I remember I got very, very angry because the House of Delegates got priority back then. And I had, the first year I chaired the meeting, I believe was in Vegas, and I invited a lot of well-established medical faculty from St. Louis University and from Washington University School of Medicine here in St. Louis, and some national figures, mostly MDs. And this was something a little bit different from podiatry in those days. And I was very angry because the priority was given to the House of Delegates. So they were getting all the breakout rooms, all the meeting rooms. And I felt like we were getting the short end of the deal. And there was a lack of respect for the academic portion of the program. And I met with the then president of the APMA and several board members, and I could see they weren't particularly sympathetic. And I was rather upset. And I remember Jim Ganley, somehow I invited him to speak, and somehow he, in his brilliance, he saw I was upset. I never said a word to him, but he saw something was wrong. He said, "Allan," he said, let's take a walk around the exhibit hall. So we walked around the exhibit hall a bit, and he said, you seem like you're upset about something. So I told Jim what was up. I said I felt it was unfair that academics was being sacrificed for political people. And Jim looked at me and he said, I should say Dr. Ganley, and he said, I'm not very good at politics. And he said, I don't think you are either. He said, but you know what? He said, we need politicians to do the things that need to be done to protect and advance the profession. And he said, you're not good at it. I'm not good at it. But we need to give room to these people who do have the capability of doing that. And I had suggested, and I could take you to this day to the room and the table, that they separate the House of Delegates from the annual scientific meeting, which they eventually did. But at that time, they just weren't prepared to do that. John George, who recently passed away, I believe, he was from Massachusetts. I believe He was the president. He thought it was going to be a good idea to do that. And I think he sort of got the ball rolling on that. So but for a long time, I never felt that academics got a fair play from the APMA nationally. And what I always have objected to is, and I've been very verbal in writing about this and verbal overtly, is the corporate influence in podiatry education. I think we allow far too much corporate influence at the postgraduate level, access to residents, and they dominate our academic programs with so-called unrestricted educational grants, which are not unrestricted at all. They provide a speaker, which they're not supposed to do. They tell you these are the topics we want to have covered, which they're not supposed to do. And the result of that is not only biased presentation of scientific material, or as the great William Osler called it 100 years ago, pseudoscience, but it limits the education that we get. Let me give you some quick examples, and you tell me if you think I'm wrong. You have overwhelming presentation of areas that are sponsored, for example, wound care products, for example, fixation devices and techniques for surgery, because you have companies that pay to have spokesmen come and give what I call infomercials, and they're lectures that are really commercials. And you get the same topics covered over and over and over again. Onychomycosis, a new antibiotic. But what never gets covered is real medicine. For example, rheumatology, or pediatric drug dosing, or geriatric medicine. I mean, podiatry, like the rest of medicine, we are overwhelmed with geriatric patients, yet we don't have ongoing education as they do in orthopedics, for example, in things like fracture management in the geriatric patient, writing for analgesics in the geriatric patient, fall risk prevention strategies in podiatry practice. We have a fair amount of dermatology, which is limited only because we have several labs competing for podiatry business, providing speakers, and it's the same speakers and the same lectures over and over and over again. Take an area like neurology. It was evident to me when I was a student that neurology would be a big part of podiatry practice. And yet, how many times do you get real reviews of neurology for people who've been in practice for a while and need a review? And the reason we don't cover these subjects is they're not sponsored by anybody. So we don't get speakers provided to educate the average podiatrist beyond neuromas and tarsal tunnels and maybe peripheral neuropathy if someone is selling a product that they allege is helpful for the treatment of diabetic neuropathy. So that's been my objection all along. And I think APMA has been very guilty of this, that they take large donations, they declare a topic to be the official APMA topic of the year, and it always comes down to the same thing. It's a company that has given them a grant, provides speakers, and it's the same topic over and over and over again. And I'm not demeaning this because I am in general practice. Onychomycosis is part of my practice, but how many lectures do we need on laboratory studies for onychomycosis or the treatment of onychomycosis? And yet every meeting, we're hearing the same thing over and over again. And I hold the scientific chair people responsible for this, and I hold the APMA responsible. I resigned last year from the Committee for Continuing Education on Council on Podiatric Medical Education because no one's enforcing any of these rules. And we're just having seminars, whether it's the state level or the regional level and the national level, that are dominated by corporate influence, and that needs to go. It's not allowed in other areas of medicine. It is not allowed in AGME programs, but somehow in podiatry, these corporations run rampant, dominating our academic experiences. And it leads to a paucity of continuing education in other areas that are very important to the practice of podiatry, but these topics are never covered in our meetings because no one's willing to pay. And I keep hearing, well, you can't run a meeting unless you have corporate sponsorship. And that's nonsense. Medicine does it, and they still charge fees anyway for you to go. And many of these exhibit halls make quite a bit of money for these state and regional meetings, and yet they still charge members. And I think you should have to pay. I mean, MDs do it, DOs do it, attorneys do it. I don't understand why we are so dependent on corporations for money. I remember the days when you couldn't get a corporation to leave samples if you were a podiatrist. I remember well those days where, you got very few samples, maybe a couple of topical creams, and that was it. And if you wanted samples, they go, well, we don't sample podiatrists. I remember those days. So I think they have far too much say in medical education. And when they get to residence, which is not allowed in medicine in general, but I was doing an ankle fracture on a diabetic patient Friday, and I was fearful that there was a certain piece of equipment that wouldn't be there. And I said to the resident, could you get a hold of Rep X? And he instantaneously got it on his phone, had all the reps' numbers, and I could talk to a rep, and they'll tell me more about the personal lives of the residents than I would ever know working with them all the time. And the problem with letting these reps get to our meetings and get to residents is it leads to early adoption of medications or techniques or instrumentation that may in the long term actually not be a benefit to the patient. We tend in surgery to adapt to new techniques before there is solid concrete evidence that these techniques are useful in the long term. And it starts getting the residents to push less academic attendings into doing things because they say, oh, well, have you tried this new IM nail? Have you tried this new medication? And it sometimes leads to irrational use of these therapies and techniques and products. So that's my biggest objection with APMA. I think they fail to enforce rigid restrictions on corporations who attempt to influence our meetings. And in fact, they dominate our meetings. And that has to come to an end. Nowhere else in medicine does this occur other than podiatry.
Well said. I've got a couple comments on that, but first, Joe, I was going to send it over to you. What are your thoughts on corporate influence in continuing medical education?
Yeah. Oh man, this is like the unfiltered episode, right?
Unplugged with Dr.
Unplugged.
Jacobs.
That's me.
We've been having this conversation.
Sorry before this is over.
Yeah. It's so timely, Allan, because so many things for our residents have started to go toward these paid courses. Like they're free for residents.
Absolutely.
And while I appreciate the opportunity for residents to learn and the donation of time, equipment, and all that goes into conducting these labs, because again, I recognize that the world is not free and that all of these things do come with costs. But to your point, if we are now outsourcing our resident education to industry sponsorship, where are the safety nets and the controls in terms of the content that is being taught? Where are the principles of what we're teaching? Where's the focus, right? We can't teach products. We need to teach principles. We can't treat medications. We need to treat pathologies. And when you understand the keys, the foundational things, you can use any system, you could use any product for the most part and achieve those goals if you know what the goals are. But if you know the product, then you apply it in the wrong situation or you get into trouble, something happens, to your point, something's not there, right? The residents aren't, I feel like they're not being offered the kind of problem solving necessarily. They're being taught a product. And I don't know what the answer is, to be totally honest, because I think what is now challenging is, and maybe you can speak to this as well as you've trained residents, the budgets that residency programs have for resident education have been going down, or some programs we've heard residents don't get much funding at all to cover the cost. So they're paying out of their own pocket to go to courses that are not necessarily industry sponsored, but are ones that they have to pay for. So in your experience with training residents and residency programs and getting budgets and those kinds of things, what do you think is the not compromise, but the marrying of these two concepts of providing as much bias free, which I recognize at some point it's hard to eliminate bias, but maybe how do we marry the idea of teaching principle-based courses without the cost of doing so for residents?
I think the residency directors, if they're going to take on that responsibility, have to take that responsibility in a serious manner, the way it's done in the rest of medicine with ACGME approved programs, which we don't do. I think residents in today's world, to a large, and there are certainly exceptions. Al Catanzariti and Bobby Mendocino in Pittsburgh, for example, that's a perfect example of an exception. They don't let the reps get to their residents. They take the education of these residents seriously. But many of these residents are functioning essentially as indentured servants, and they're running from surgery center to surgery center, from operating room to operating room, and they're not really learning. They're doing the paperwork for the attendings. In some instances, they're doing ghost surgeries for the attendings who are not capable of doing the cases they scheduled, but they know a resident will be there to do it. And I anytime I've tried to lecture, for example, here in Missouri 2 years, because I, even though I'm not at a college, I have a tremendous interest in medical and surgical education, and I do a great deal of reading in that area. And I try to share those concepts with my fellow podiatrists, and there's absolutely no interest in that. So when I have a case, I sit down with the residents before the case and let them know what it's all about, what my reasoning was, right or wrong, get their input. I always make them look at radiographs of the deformity before we go about addressing it, if it's appropriate to have radiographs. And then after the case, I sit down with the residents on Fridays. My wife has always put up with this. And I sit there as long as they want. And I say, let's talk about what we just did. And this is the best time to now read about that particular procedure, whether it's a bunionectomy or an ankle fracture or anything in between. You just got done working with one. Now's the time to go back, look at different opinions, different approaches. But these things take time, and it takes a serious effort on attendings to want to do that. And most attendings, quite frankly, really aren't interested in advancing podiatry education. I'm not saying that they have a responsibility to do that, but I think if you do work with residents, I feel you should feel some obligation to advance them in some regard, just not have them show up, do the paperwork, assist you, and then make sure that everything's dictated and signed for me. And by the way, take my questionings from the board for me, and that's it. And then I think there are steps that are well documented in educating residents in surgery, and at some point you have to let them go and stand there, as much as it hurts, and watch them try to work themselves out of certain problems. Because if you're always standing there, you're never allowing them to develop the feel that you need to do surgery, and they need to develop that feel. And that means doing part of the procedure or doing the entire procedure. And more importantly, resisting jumping right in, but letting them work things out because you had to work things out, and then sitting with them afterwards. I think that those are things that go into good education. And it just doesn't happen enough in our profession, in my opinion. And I know there are exceptions. I'm sure there are exceptions, but it's the exception, not the rule. And I hate to see how residents are used in the manner that they're used as I say, they're indentured servants. They have to serve for 3 years. And the other thing I always warn attendings is residents know what they see. And if they see unethical behavior that goes unpunished, when they see unnecessary surgeries being performed, when they see poorly performed surgery go unchecked, they assume this is acceptable. And I think it's a problem. And residents are used that way. I can't stand it when I walk into the doctor's lounge and I see a resident taking the mandatory quarterly questioning to maintain your boards for an attending. And I contacted the board and I said, you realize that in this country, there are residents routinely taking the retest because it's computerized and there's no security whatsoever, taking the retest for the attendings. I said, how does that ensure quality care for the public? And I'm told, well, we know that goes on, but the test is really meant to be sort of a reminder. So when you have that kind of thing going on, when you allow corporations to wine and dine these residents, when they see the attendings sell out to these corporations, when they see some of the things they see, it makes them wonder, are there any ethics in here at all? And that doesn't happen in the remainder of medicine generally. I know that the rest of medicine's not pure and they've got their issues too, but they see this a lot, and it's hard to educate somebody when they realize that unethical behavior and poor technique is tolerated. And have attendings who really don't sit down and spend their time with residents. And that's what's required if you really feel that you want to contribute to the future of this profession. Because anybody, my old teacher, Dr. Kaplan, was my residency professor, and he said you could learn from everyone. Scrub nurse, person that cleans the room, whoever. There's something to be learned from every single person. So even the most non-read, non-academic podiatrist, I guarantee, has some insight into some problem that would be helpful for the residents in the future. But most of them don't do that. They run in, do the case, run out, and there's really no education that goes on.
Good point. Allan, what do you think about the changes in technology in the delivery of CMEs? You're seeing so many CMEs online. I'm starting to say, in my mind, I'm imagining this marriage between education and what the companies and the products have, because they're flying residents all over the country to their training centers and they're teaching them. Maybe the educational portion needs to be more online, and then they can go do their skills labs elsewhere. I mean, I'm not sure what the answer is, but maybe we take advantage of technology in some way.
I think the residency directors and fellowship directors are ultimately responsible to set a standard that the residents say is a great standard, and that's what I want to follow. And I hate to sound negative about that, but I just think that is lacking to a large extent in our profession. I don't know why, but it is. And I don't think there's an esprit de corps for advancing things. I mean, I'll give you an example of corporate influence. I had a patient who had a non-union from a midfoot Hoke arthrodesis. And she came and saw me, and she had symptomatic non-union. So I revised it. I also got a non-union, by the way. And anyway, as I'm following her post-op, she says to me, would you mind if my daughter came to your office? She's a first-year student at one of the podiatry schools. And I said, sure. Now, this was December. So she's on school break. She comes to my office, and she's kind of quiet at first. And she's been in podiatry school now, September, October, November. We're into December. So the first question she asked me is, how many external fixators do I put on per year? So I thought that was a strange question from someone that probably doesn't know how to do a P&A and hasn't even passed their anatomy yet. So I answered her question, and her second question was, how many? And she said to me, I know they're controversial. I go, what do you mean controversial? She said, external fixation. Well, it's hardly controversial. I said, I do a lot of static frames, primarily for Charcot. I said, I don't do active deformity correction with frames. I'll refer those out. but I said, I do a lot of static frames. And I said, why do you think it's controversial? And she was in her 4th month at this particular podiatry college. It was not yours, and already had had 2 corporate sponsored courses in external fixation. Mm-hmm. And here's a girl that doesn't know how to do a PNA yet. Okay. Their second question was, how many ankle fractures do I do per year? So I stopped and I said, I need to know something. What are they telling you you're going to be doing as a podiatrist in the future? And she had this, misperception, I think. And I said, well, if you are in certain circumstances, you probably can limit your practice if you go to a Kaiser or work for an orthopedic group or perhaps certain medical groups. But in general, you're not going to make your living doing Charcot recons and ankle fractures. That's really, but the other side of this with resident education, and you two are much more involved in student education than I, is that they don't get medical training. Because when they're residents, they're going from OR to OR, surgery center to surgery center. The only medical work they do is our inpatients, generally infected diabetic feet. But that's it. They're not really getting training in rheumatology or neurology or real dermatology, other than arguing about doing, PCRs or fungal cultures and whose lab you should use and who's giving more money to whom. So they're really not getting good medicine. So when we graduate these 3-year podiatric medical surgical residents, they go out and all they've had is mostly surgical training. And now someone comes in with heel pain, and you're not going to do a plantar fasciotomy right off the bat. You're not going to do a gastroc recession right off the bat. And you really don't have many options available. You kind of know they probably need an injection. You don't have any idea on biomechanics, because somehow biomechanics has gotten lost in our programs. I ask the residents all the time, and I probably shouldn't say this, but I do. I conduct my own little secret surveys just to see what's going on. And I ask the residents, how often do you see the attendings stand up and walk a patient? And they say hardly ever. And I don't understand how you can make a decision on any type of functional surgery, hammer toes, bunions, pronation deformities, whatever. How do you do that without watching a patient walk? I mean, I don't get it. And yet, again, that's how they're being trained. So this is something else I would change. And there's no fall prevention going on. They're not asking patients, risk of falls, or do they feel unstable, or have they fallen, or are they fearful of falling, and maybe making appropriate referrals. We just don't emphasize the medicine. And they come out and they're poorly trained. And I think when we say PMSR, it's really podiatric surgery, but the medicine part, I think, is underserved unless you're seeing something different in Arizona. I just don't see it.
Allan, I'm seeing pockets around the country where the 3-year medicine and surgery residency programs are doing justice to the medicine. And the reason I say that is because I get a lot of comments from residency directors about the quality of our students' medical education coming into the residency program. And they are on rotation. They are treated like interns. And so I'm pleased with that, Allan, because I think that we're on the right trajectory. I just don't think that that's the majority or anywhere close to the number of programs out there. I don't think they get that experience.
No,
so I think you're right.
And I think if they don't get it in their residency, I know they get it in schools. I work a lot with Mike Treppel with the New York College, and I know the effort that he puts in, for example, to emphasize the medical aspects. And it's very admirable he does that, but it doesn't get reinforced in residency. And then and when they go out, these students, these residents are confounded with a swollen joint. And if it's not a hallux limitus or gout, they have no other differential diagnoses to offer you.
Well said. So, Joe, do you have any other questions on this line of thought? I was going to shift gears a little bit.
No, and that, it's really interesting. And in fairness, this is my own personal ignorance, is just in terms of the structure of the residency programs. I know that there are requirements that every program has to meet, but I don't know how much parity there is. If it's literally a matter of like, check the box, you did internal, to your point, Allan, internal medicine, and that is sufficient to meet that metric, versus the quality of the rotation of what they're actually doing. And again, having worked with lots of different residents now, over the last 2 years, and in certain aspects, there is a huge diversity in what we get from the people in front of us. And I don't know the right answer in terms of how to improve that standardization, but I do agree, Allan, that there are absolutely areas that I think our profession has room for improvement. We need to maybe focus a little bit more in terms of what that would look like to standardize and have better accountability to what these residents are doing in these rotations, to make sure that they are getting a well-rounded medical surgical experience during residency. Because you're right, a lot of what you're going to do when you come out in real world practice is not going to be surgery all day, and you need to be able to understand a differential diagnosis and work that up. So again, some of that's just my own. I'm not a residency director. I don't know all the details that go into that. I know there is a ton of stuff that they do have to do in terms of approvals, but perhaps opportunities for finesse, as Dr. Yoho is my new favorite word, areas to finesse.
Very well said.
Well, I think there is a lot of box checking that does go on. And oftentimes the residents, and again, I understand it's not universal, but oftentimes they follow on a rotation, but they're not participating the same way an MD or DO resident is participating. They're really not caring for these patients. They don't have the same responsibilities. And let me give an example. Here in St. Louis, the neurology rotation is with someone who specializes in extrapyramidal tract disease like Parkinson's. Well, that's fine. But here's a nice neurologist. He gives up his time. They follow the guy around for a month. Well, you come out learning a little bit more about Parkinson's. But what about what podiatrists see most commonly? Peripheral neuropathies, for example, spinal stenosis manifestations, things like that. That goes untaught.
Yeah.
So it's great when you have the Parkinson's patient in and you say, oh, I know the drugs you take for that. But again, the neurologist isn't involved in gait assistive devices for a Parkinsonian patient, or, shoeing a Parkinsonian patient, whatever. So yes, you check off a box. Oh yeah, they did a rotation, but it really wasn't that much of a rotation. And some of these things are critical. I mean, look how important infectious disease is to podiatry in this world. You can't be a podiatrist and not involved with treating infection, that type of thing. And it's got to be a worthwhile, real rotation. And I think a lot of times that's not what's happening.
I agree with you. I agree with you, Allan. Shifting gears just a little bit, you are in the Podiatry Hall of Fame, and congratulations. I mean, I don't know how many there are, but there aren't that many. And you're there for all of your contributions to the profession, in spite of Allan Jacobs Unplugged, right? So what did that mean to you, getting in the Hall of Fame, Allan?
Well, it was a surprise, and what it meant to me was feeling that you were appreciated by your colleagues for years of work. I do think, like many people, I put a lot of time into this profession, many weekends away, and the person that should be in the Hall of Fame really at times should be the family. A number of years ago, I was in San Antonio giving a dinner talk, and I had, out of nowhere, I had a massive cardiac event. And all of a sudden, I go from not ever taking a pill in my life to laying in an ICU, being told there's a chance you may not make it out of here. And I was in there for 2 weeks in a city I didn't know, doctors I didn't know. Anyway, so my wife comes down and she's staying with me for the 2 weeks, and I had a pump in my chest and the whole bit. And I'm holding her hand and I'm looking at the little ICU clock, and I realized suddenly that I'm old, and it went so fast. And I went from having a good time going every weekend to different meetings and meeting all the wonderful people in our profession and watching this profession grow. And all of a sudden, like, I'm old, and I'm holding my wife's hand, and I said, "Where did it go?" I mean, it just went so fast. And she said, "Listen, I will never forget it." She said, "You're the one that chose to spend your life with students and residents and podiatrists. And I never objected because I knew that was important to you. But don't ever ask me where the time went. You made that decision, and I knew it was important to you, so I supported you." So, and I think I did put a lot of time into this profession away. And it was nice because that caught me out of nowhere. It's not like you can, I only know two people that actually campaigned to be in the Hall of Fame. And there are two people that actually wrote letters right into Barry Block, support me, I want to be in the Hall of Fame. But other than that, it was nice to get a thank you like that from the profession. It just was, because you put a lot of time into this if you're sincere about it. And it is a lot of time away from your family. And it was nice to have a bunch of people say thank you for, what you did, and we appreciate it. It was much better than just getting, a plaque at a meeting saying thank you, sucker, and we're moving on. It was very, very nice. So I appreciated it in that regards. I don't think it made me any special in terms of being better than anyone else. It was just nice to know that enough people out there thought enough of you to say, we'll vote this guy into the Hall of Fame. So that's what was nice about it.
Absolutely. Congratulations. I just think it's one of the pinnacles in our profession. So I wanted to bring it up. Joe, your thoughts?
The opportunities to engage with the future of the profession and the amount of time and dedication that you have given to the profession. Again, I'm trying to figure out how exactly, how to express that kind of gratitude, because it's laying that foundation. And even now, talking about how do we make things better, right? We still have a ways to go, perhaps. And there's always opportunities for improvement. And unless you're willing to be honest about this and open to discussion. And I loved your initial story that you talked about at the very beginning, the frustrations about the academics sometimes being pushed to the side and the political, and having that moment of empathy from your friend to say, I hear you, I feel you, but this is also important and we need to make room for that. And I think perhaps part of what I'm also hearing you say right there with that story is dedicating your life to something and having that opportunity to be recognized is valuable, but then also realizing that the things that make this world so special and life so special is inherently some of its fragility. And so we do get to choose how we spend our time and what we do with it. And so hopefully we feel good about what we've chosen at the end when, you're starting to look back and say, well, if I could go back and spend another 40 years, how would I want to spend it? And so I appreciate you sharing that moment of vulnerability there was really touching.
You have to want to do it. And I go back to a time when you didn't get honoraria for lecturing, and you were insulted if you weren't asked. I mean, I remember, Jeff, I don't know if you're old enough to remember the Hershey meeting.
Yes, I never went to it, but I do remember it. Yes.
Okay, so at one time, as you know, that was as large a meeting as we had in our profession, and everyone's goal was to be invited to be a speaker at Hershey. That was the pinnacle of our profession. And you had to earn your way along. So first you had to work the projectors and the slides. I'm sure many of your listeners don't even know what slides are, but at one time before PowerPoint. And then you sort of got you had to work the labs till late at night, because we'd work over at Milton Hershey Medical School in the cadaver lab. And if people wanted to stay till 3 a.m., you were there till 3 a.m., or Bill Goldfarb would let you have it. And and you didn't get honoraria back then. You got a room, you got free meals, and that was about it. And so the people back in those days, the great leaders in our professions, the McLamorys and the Earl Kaplans and the Jim Ganleys and all those people, they were doing this because they wanted to do it. They weren't doing it because a corporation was giving them a check for $2,500 to lecture. And sometimes now I see people honored for their dedication, and I often wonder, if you look them up online, you'd see that some of them are making $500,000, $750,000, $1 million a year consulting and lecturing. So I don't know that that's necessarily dedication. It's more business. But I remember the days when, if you didn't get a chance to lecture, you were insulted. Like, why wasn't I invited? And you'd be upset about it, but there was no money involved. These were people. Our profession was built by people who wanted to do that. The Irv Kanets there's hundreds of them to name. And I remember very well when they put that time in. And we need people like that to drive our profession still, and they do. It's a growing profession. It's a great profession. I think we probably talked about this the first time. Look at the future of this profession. It's going nowhere but up. And so those older guys and ladies, mostly guys, because back then there weren't that many women in podiatry. We had one woman in my podiatry class. That was it. Elaine Carville, and she was an ex-Marine, so nobody messed with her. And she used her money to go to podiatry school, and that was it for women, I think, in the entire school. I don't think we even had another woman in the entire 4 years. So back then it was mostly male driven, but these were people that were very dedicated, and they were passionate about advancing this profession, no doubt. And we still have some people that are like that, but we need to keep that up to make things move.
To all of our listeners out there, thank you for listening on Apple Podcast and Spotify. And if you're watching on YouTube, by all means, become a subscriber. One of our goals in working with Dean's Chat is to bring wonderful, insightful doctors that have made a difference in our profession, and you tick all the boxes. Dr. Jacobs, thank you so much.
You're welcome. Thanks for having me.
You're welcome. And like Joe said, we're going to send you more cups, and cheers, and we'll see all of you next week. Bye-bye.